Today we are going to talk about thalassemia. Thalassemia is commonly hemolytic anemia with microcytic hyperchromic blood pressure. We'll see in detail about each type of thalassemia and different varieties inside thalassemia. Commonly, anemia is classified into or due to blood loss, increased RBC destruction, that is hemolytic anemia, and decreased RBC production. Commonly, hemolytic anemia is when there is increased destruction of RBCs in the periphery after it is formed from the marrow, and it is divided into inherited and acquired. And also hereditary. Coming to hemolytic anemia, here we can see that it's classified into hereditary and acquired. Under hereditary, there is hereditary spherocytosis, hereditary erythrocytosis, and due to abnormal red cell interior, there is due to hemoglobinopathies, it is sickle cell anemia and thalassemia, and also due to enzyme defect, is G6PD deficiency. And coming to acquired, there is paroxysmal nocturnal hemoglobinuria, immune hemolytic anemia, and microangiopathies due to DIC, TTP, and also due to toxicities. And as we saw, it is divided into hereditary and acquired or inherited. The same thing is seen here, and here it is giving an example of inherited hemolytic anemia and its cause. Like in our red cell membrane disorders, it's hereditary spherocytosis due to G6PD deficiency in the HMP shunt pathway. G6PD deficiency is seen, and then due to globin synthesis deficiency, synthesis and its deficiency, thalassemia is seen. And sickle cell disease is due to replacement in the 6th chain with where guanine is replaced by valine. And the same thing here, acquired examples. And this is telling us the same thing about different types of hemolytic anemia. Now we'll see in detail about thalassemia. Before going to thalassemia, let's have a look at hemoglobin. What is the structure of a hemoglobin? So we'll understand about thalassemia better. Commonly, hemoglobin is made up of 4 chains, that is 2 alpha chains and 2 beta chains, and 4 heme groups. That is, here you can see the dots, blue and black round around it, that is the heme. So it has 4 globin chains and 4 heme groups. So usually heme is made up of 2 things, that is an iron and protoporphyrin ring around it. And these 2 globin chains that we talked about is made up of 2 alpha chains and 2 beta chains. So alpha chain usually contains 141 amino acids and the beta chain usually contains 146 amino acids. These globin chains are usually protein chains. These hemoglobin is part of an RBC that helps to carry oxygen and supply to different parts of the body. So there are about 3 million of hemoglobin in one single RBC. So each hemoglobin can carry 4 oxygen molecules. So one RBC can carry about 1 billion oxygen molecules. Coming to thalassemia as such, usually thalassemia is due to deficiency in production of the chains. That is usually alpha or beta chains. When there is alpha chain deficiency, it's going to be called as alpha thalassemia. When there is going to be beta chain deficiency, it's going to be called as beta thalassemia. It is an autosomal recessive disorder. Taking a look at these chains, that is beta chain and alpha chain. Commonly, the alpha chain is present on the chromosome 16, and it has zeta unit and alpha 1 unit and alpha 2 unit. Coming to beta chain, it is present on chromosome 11. From the embryonic to the adult, it has epsilon, gamma, delta, and beta. Hemoglobins that are present in our body are embryonic, fetal, and adult. So this is from the fetus, then to the childhood and adults. So seeing embryonic hemoglobin are seen in the fetus commonly before 6 months, for the first 6 months of the life. So those are HB Gover 1, HB Gover 2. HB Gover is as zeta and epsilon, that is 2 unit of each, and HB Gover 2 as alpha and epsilon, 2 unit of each. And coming to fetal hemoglobin, that has 2 alpha and 2 gamma. This is commonly seen after 6 months of life, and adult is commonly seen in the after the baby is born. So post 6 months it starts production, but it can be seen in the after in the adult life. Common adult hemoglobin are 2 alpha, 2 beta, and HbA2 is also present, that will have 2 alpha and 2 delta. So each adult will have mostly 95% as 2 alpha, 2 delta, and 5% can be alpha 2 and delta 2. Coming to thalassemia, as we discussed, it's made up of two types of thalassemias, alpha and beta. That's what is discussed here, whatever we discussed in the previous slide. So taking a look at thalassemia, it is usually autosomal recessive disorder. It's commonly seen in the Mediterranean region, and it has autosomal recessive trait, that is 25% will be sick and 50% will be carriers, and the 25% will be healthy. Consequences of thalassemia is due to hemoglobin deficiency and relatively excess of the other hemoglobin. Like in alpha thalassemia, there will be excess of beta chains, and in beta thalassemia, there will be excess of beta chains. Coming to beta thalassemia is commonly due to deficiency of beta globulin chains, and it is due to point mutation. That is very, very important. So it has 2 alleles, B plus and B0. We'll take a look into it. So B0 is when there is absent beta globulin chains. There is no beta globulin chain, and B plus is when there is reduced production of beta globulin chains. So usually beta globulin chains are present in chromosome 11, one pair. That's one pair. So each chromosome will have one gene only. So we'll have 2 chromosomes for each gene. So 2 chromosomes will have 2 genes. The mutation are of 2 types, that is, as we discussed, B0 and B plus. So it is commonly due to point mutation we discussed. So there are different types of point mutation: splicing, promoter region mutation, and chain terminator mutation. The splicing mutation is more commonly seen in beta plus thalassemia, and chain terminator mutation is commonly seen in beta 0 thalassemia. The common pathogenesis is there is deficit of HbA synthesis because there is alpha beta chain deficiency, and there is imbalance between the alpha and the beta chains. Like we discussed here, in beta thalassemia there will be excess of alpha chains. These deficiency lead to 2 main things, that is ineffective erythropoiesis and extravascular hemolysis, and I'll discuss in the further slides about these 2 conditions, that is ineffective erythropoiesis and extravascular hemolysis. So coming to pathogenesis of beta thalassemia, if you can follow this chart, it will be very, very useful. So what happens first is there is impaired beta globulin chain synthesis due to that leads to formation of abnormal erythroblast that causes ineffective erythropoiesis. Abnormal erythroblast, that is proerythroblast, lead to ineffective erythropoiesis. So an RBC is usually formed from the stem cell, it is formed from a pluripotent stem cell. From there it develops into a proerythroblast, that is then it develops into early, intermediate, late normoblast, then it develops into reticulocyte, then develops into a adult RBC. So here, due to abnormal erythroblast, there is ineffective erythropoiesis. Normal RBCs are not formed. So that leads to anemia. So when there is anemia, there is going to be tissue hypoxia, and when there is tissue hypoxia, the erythropoietin level that is produced by the kidney, that increases. So that causes extramedullary hematopoiesis, that is hematopoiesis occurring in other organs other than the bone marrow, like the spleen, lymph node, liver, etc. And also due to some in the early stages of life, that is fetal life, the bone marrow is produced from the end of the long bone, so those area also comes in the aid for the hematopoiesis, so leading to expansion of bone. So due to extramedullary hematopoiesis, there are going to be hepatosplenomegaly, and due to expansion of bone marrow leads to skeletal deformities. This extramedullary hematopoiesis and hematopoiesis in the bone lead to increased erythroferon. This erythroferon, what it does is it suppresses the hepcidin level in our body. This hepcidin is a hallmark in iron absorption. So when there is hepcidin suppression, this leads to increased intestinal iron absorption. So when there is increased intestinal iron absorption, and there is also ineffective erythropoiesis, it can't produce normal RBCs. That's going to this increased iron absorption is going to make sure there is going to be systemic iron overload. So this systemic iron overload, what happens is it leads to hemochromatosis, that is secondary hemochromatosis, that is happening due to some other cause. So commonly in thalassemia patient, their blood transfusion is the treatment of choice. When there is blood transfusion also, there is going to be iron overload leading to systemic secondary hemochromatosis. So coming to the last part, that is the third one. So few abnormal cell enters the circulation. That is when there is ineffective erythropoiesis, abnormal erythroblast, few abnormal cells enter the circulation. These few abnormal cells, what happens is they get precipitated because there is excess of alpha globulin chains, leading to extravascular hemolysis in the spleen. So there is splenomegaly due to this also. These abnormal RBC are destroyed in the spleen, leading to splenomegaly. So this is the pathogenesis of beta thalassemia. So beta thalassemia is commonly divided into three major things: beta thalassemia major, beta thalassemia intermedia, beta thalassemia minor. So beta thalassemia major is when there is abnormal beta units, that is B0, B0, B plus, B plus, or B0, B plus, or everything will be abnormal. So these patients usually is a form of a severe thalassemia, so they need blood transfusion and hematopoietic stem cell transplantation for survival. Coming to beta thalassemia intermedia, this is when there is one normal, one normal is there, one abnormal is there. So it is usually this is not very severe, so they do not need many transfusions, but it is compared to beta thalassemia major, it is less severe. In beta thalassemia minor, it is very less severe, so it is mildest form of anemia. It can be of any traits like the B0, B plus, anything, but it is a very feeble type of thalassemia, so there will be mild anemia. So commonly beta thalassemia manifests in the 6 to 9 months of life after birth, because HbF switches to HbA, that is 2 alpha to gamma switches into 2 alpha to beta. So common clinical feature in beta thalassemia is called chipmunk faces. So they'll have large deformed skulls, frontal and posterior bossing, and prominent zygomatic bone and depression of the nasal ridges, malocclusion and overgrowth of maxilla. So this is called as chipmunk faces. You can compare these two photos. And other bony deformities like expansion of metacarpal and metatarsal bones, broad ribs, and shortening of the long bones can occur, and vertebral body overgrowth can also occur, leading to spinal cord compression. So whatever we discuss is shown in this picture. And coming to X-ray, there is going to be hair on end appearance or crooked appearance. So you can see at the end of the skull there is like a hair on end appearance, and this is also called as crooked appearance. So in beta thalassemia there can also be growth retardation, repeated infection, hepatosplenomegaly, like we discussed in previous slides. So the common lab diagnosis here will be there will be low hemoglobin levels and hematocrit will be low, that is MCV, MCH, MCHC, and peripheral smear will usually commonly have microcytic hyperchromic blood picture with anisopoikilocytosis, that is different shape and sizes of RBCs with peculiar RBC features of target cells. That is very common in beta thalassemia, that's thalassemia as such, and also they'll have basophilic stippling and immature erythrocytes can be there, that is nucleated RBCs can be there. And here you can see abnormal anisopoikilocytosis and also microcytic hyperchromic RBCs and target cells and nucleated RBCs. And here you can see microcytic hyperchromic blood picture with abundant target cells with few nucleated RBCs. These are the clinical lab features in beta thalassemia major, that is reduced serum haptoglobin, increased bilirubin, increased urobilinogen, and increased iron levels and increased ferritin levels. So acid elution test will have increased HbF levels, and in hemoglobin erythropoiesis is also aids in diagnosis that will demonstrate HbF, HbA2 and levels on a higher percentage. Treatment is commonly blood transfusion and hematopoietic stem cell transplant. This view. Coming to beta thalassemia intermedia, the type, this is normally less severe form compared to the major. They'll have mild splenomegaly, minor growth retardation, infection and leg ulcers. They'll have in electrophoresis, they'll have HbF 10 to 30%. Coming to minor, less severe, very less severe form. They are heterozygous states, and they'll commonly have microcytic hyperchromic blood picture. These are the other clinical features in trait, and it's not very severe case. And here you can see nucleated RBCs, basophilic stippling, and in electrophoresis you can see HbA2 level is increased. And commonly in beta thalassemia minor, Nestrov test is done. This test as a principle telling us that these microcytic hyperchromic cells with this trait of beta thalassemia are resistant to lysis compared to the normal RBCs. So here what we do is we have two negative and positive tests. So here you're going to take a buffered saline and you're going to take distilled water. You're seeing in positive test, like the one that is blurred is positive, that will have the beta thalassemia patient's blood group. So what will minor beta thalassemia patient's blood group, and that will usually be very blurred because they are not going to get lice, so you won't be able to see the line behind. So commonly after the blood is put into distilled water and buffered saline, in distilled water usually they will get lice, but in buffered they won't be lice. So when they are kept in front of a white sheet with a line, when we are not able to see through the line, it is positive. Like in positive test we are not able to see through it. In negative, the patient is normal, he doesn't have beta thalassemia. Coming to alpha thalassemia is another form of thalassemia where it is commonly due to deletion, and there are usually 4 genes that are involved here. In beta thalassemia 2 genes are involved. So there are 4 types of alpha thalassemia: silent carrier state, alpha thalassemia trait, HbH and hydrops fetalis. We'll discuss each one. Silent carrier state is commonly deletion of one of the alpha unit. So out of the 4, we told 4 genes, 1 gene will be deleted. So it is commonly is slight microcytosis will be there, and it is a very less severe type. Coming to alpha thalassemia trait, there will be deletion of 2 genes. So there can be deletion of alpha deletion and normal alpha deletion, or there will be that is in homozygous. Heterozygous, there will be deletion of the first two genes and the last two genes will be normal. So both of them will have similar clinical features. This is most common in Asian population. They'll have microcytosis, hyperchromia and mild anemia, and HbA2 levels are commonly normal. So like you can see here, in 4, 2 are deleted, that is heterozygous state, the first two. In homozygous state, the one is normal, next is deleted, next is normal, next is deleted. So this is the trait. Like you can see here, the first two things are deleted, next two things is normal, next one there is first is normal, deleted, then next is normal, then deleted. So they have minimal to no anemia, microcytosis will be present, HbA2 levels will be normal. HbH, here what happens is all three genes will be deleted, so only one alpha gene will be normal. So what happens in these cases will be, due to there is very less number of alpha, that is all three are deleted, only one gene is there will be increased beta globulin chains in these population, leading to formation of something called as beta tetramers. Like you can see here, all three are deleted and only one alpha gene is present, so it's also called as HbH disease. So due to this very decreased level of alpha chains, there's going to be normally increased beta chains, like we discussed, and there is very decreased number of alpha, there's going to be increased number of beta chains because it's going to be normal. So that is going to lead to a scenario where there's increased beta chains called as HbH or beta tetramers. These beta 4 tetramers have high affinity to oxygen. So normal hemoglobin will carry less oxygen and deliver to the tissues, but these beta 4 tetramers will just absorb the oxygen present and it won't be able to release it to the organs that is necessary, so leading to tissue hypoxia. And also these beta tetramers are prone to oxidation, so they precipitate and form intracellular inclusions, leading to sequestration and hemolysis, leading to anemia, moderate to severe anemia. The last type of hydrops fetalis, this is commonly seen in child. So it is commonly seen in the after 6 months of life, because in the first 6 months the embryonal hemoglobin compensates for these compensate for the disease. So they will usually have alpha and zeta, or alpha and epsilon. So they compensate for the disease, and what happens is these patients, they won't have any alpha chains, so all 4 chains will be deleted, leading to formation of gamma tetramers. Like in fetal life, I told in fetus there will be alpha and alpha 2 alpha 2 gamma. So when the alpha is completely deleted, after the embryonic hemoglobin switches to fetal hemoglobin, there will be alpha 2 and gamma 2. So when alpha is deleted, the gamma tetramers are formed, HB bracts are formed, leading these patients usually don't survive because all 4 alpha chains are deleted, leading to hydrops fetalis. So here you can see why I told why they don't have in the earlier part of life, because the zeta chain compensate for it, zeta and gamma compensate in the earlier part of the life, but when it switches to fetal hemoglobin, all 4 are deleted, leading to gamma tetramers. So these commonly evident in 3rd trimester. They usually will have severe pallor, generalized edema and massive hepatosplenomegaly. I can see all 4 are deleted. This is a gross picture of hydrops fetalis. So lab diagnosis, commonly they'll have mild to decreased hemoglobin levels and low hematocrit, that is MCV and MCH, and mild microcytosis on peripheral smear. HB electrophoresis is commonly diagnostic, and molecular testing can also be useful in these tests to detect the alpha deletion. So in electrophoresis, HbH and HbBAT can be easily diagnosed. Treatment, commonly blood transfusion, ion chelation therapy, and avoiding oxidant drugs, because commonly it is oxidation lead to inclusion formation. Thank you.